Good morning, everyone, and thank you for joining the CQC team for the first webinar in the Accelerating Integrated Care series, Align Payment. We're really delighted you're all here to join us today. As a reminder, this session is being recorded and will be available to you after the webinar is complete. The webinar recording and the slide deck will be sent via email to all registrants after today's webinar. Before we get started, I would like to review a few Zoom tips. So if we could go to the next slide. Thank you. All attendees are automatically muted upon entry. There will be a couple of polls throughout the webinar, and when the window pops up, make sure to select your answer and to click the blue submit button to make sure that your answers are logged. If you are having any technical issues throughout the webinar, please direct in chat your messages to me, Michelle Ma, and I will try to assist as best as I can. And throughout the webinar, please feel free to chat in the box with any questions or discussions or anything like that. So at this time, if everybody could please chat in your name and your organization, that'd be appreciated. And as everyone continues to chat in, welcome. We're going to launch our first poll, and it's just to kind of get an idea of where everyone is dialing in from. So first poll, from where are you dialing in? And also you can scroll down the window for the second question, what type of organization do you represent? Select your answers and make sure to click the blue submit button. Is everybody seeing the polls? Okay.
Michelle, do we have our results in from the poll?
I'm not seeing any poll results. That's strange.
Okay.
Already having technical difficulties. Sorry about that, everybody. For those of you who did vote, thank you. I appreciate that. Okay, so at this time, I'm going to hand it over to Crystal. Thank you, everybody.
Hi, everyone. Good morning and welcome to our webinar this morning. Before we dive into what we're going to cover today, I just want to share we're the California Quality Collaborative, and we're a group that represents we are made up of members of health plans and other stakeholders within the California healthcare delivery system, trying to advance quality and efficiency in any way that we can. And to that end, today's kind of launch of a new webinar series is taking us further in behavioral health integration and focusing on how do we make this happen faster in California. This was our plan before COVID, but now that COVID is here and we're in a new world, it's even more important and urgent that we work to accelerate integrated behavioral health into primary care. Let's see. A little trouble with the slides real quick. Let's see. Michelle, I'm going to stop share real quick. Could you bring up the slides and I will continue talking while you do that? Mine is not moving forward.
Sure, I can do that.
Okay. So yeah, today, we are, as I mentioned, we're launching a series today that's focused on integrating behavioral health and what does it take to bring everyone together, payers, purchasers, providers, to really make this happen. And so this is the first of a series, and there's going to be several topics in which I invite you all to tell us what you want to know about. And so I thank you for those that entered in suggestions into the webinar registration of additional topics you'd like to hear about. We're going to be framing these around a paper that we did. We have the author today with us, Melora Simon, a paper that started as an analysis of reaching out to providers within California and health plans of what are your barriers to behavioral health integration, right? Why is it not going as fast as we thought? Let's figure out what are these barriers and work together to find some solutions. And so that paper, Michelle, if you could go to the next slide, was generously funded by California Healthcare Foundation, thank you, and was just released at the end of May. And so it's weaving together mental and physical health care outside the safety net. And that is downloadable through the CHCF website, and we'll put that link in the chat for you guys if you want to see the full paper. But Melora is going to give us the synopsis today, and we're going to focus on one piece of this, which is really about aligning payment, because usually before we can jump into just changing care, we have to set the right incentives to make it easy for people to choose this choice. And so how do we align payment and move things forward with those payment structures? Next slide, please. So there's a quick sense of our topics, and we'll be releasing the dates of these webinars. Next slide, please. Yeah, so today we're going to hear from Melora about kind of what is the current state, what are these challenges that she uncovered, but in this, what she uncovered as she investigated was some real innovations happening, and so that's why we have our speakers here today. And what are those innovations that were enabled by aligned payment when people are working in coordination and together, that we can take this forward, and from that for you guys to hear about what could you do from these action steps, right? So you're going to hear a lot, and we're not going to jump into, super cool payment structures immediately. So what are some more simple steps that you can take towards this direction, no matter where you are on the spectrum of your integration journey? Next slide, please. So we'll be hearing from Melora Simon, who is a healthcare strategy and innovation consultant and previously the senior director of care redesign at the California Quality Collaborative, and authored this paper with Muriel Moi. And we'll hear from Dr. Tiffany Nelson. She is a physician, I think founder of an independent practice in Arizona called Desert Ridge Family Physicians, as well as Chief Strategy Officer of Innovation Care Partners, which is an ACO in the Phoenix area, encompassing 300 partners and the innovation work that she has done in working with Concert Health. And then we'll have a presentation from Julie Fortune, and she is the Director of Behavioral Health and Primary Care Integration at Providence St. Joseph Health in Anaheim, and she has worked with us on some other projects and sharing her expertise. And so we are happy to have all three of them here. And feel free to, as we go along, chat in questions. So we're going to be monitoring the chat box. Put your questions in there, comments, thoughts, whatever you want to share. And we'll make sure that we tee those up for everyone, because towards the end of our session, we'll have a broad just Q&A, big chunk of time that we can pick their brains with Melora, Dr. Nelson, and Julie. Thank you. I will hand it to Melora.
Thanks so much, Crystal. Michelle, can I have the next slide? So I'm going to very, very briefly talk about the case for change, because that's an important place to start. But I'm going to go through this quickly in terms of presenting the data from the paper, because I want to give Dr. Nelson and Julie a chance to really tell their story. But as we all know, mental health conditions are really common, and access is difficult regardless of insurance. So more than half of people who are trying to access specialty behavioral health care are finding that it's difficult to do so. Michelle, next slide. And the reason that we think integration in primary care is the right place to start and the right place to work is because that's where these issues are presenting today. So 80% of antidepressant prescribing is happening in primary care, but primary care is kind of ill-equipped. So just like with hypertension or diabetes, the first treatment doesn't necessarily work. And for more than half of patients, they need that stepped care, that titrated care. And at some point, it gets to the end of the scope of the PCP. And so that's why we think that integrated care is really, really important. Next slide. And finally, when we talk to patients about this, they want integration, they want coordination, they want behavioral health and primary care to be working together in the vast majority of cases. But unfortunately, it's pretty rare, particularly in California. Next slide. And when we talk about integration, when people say integration, they can mean a lot of different things. But when we talk about integration in this paper and in this webinar, we're really talking about practice change. So not just coordination and communication or co-location, but actual collaborative care. So behavioral health clinicians and physical health conditions working together to help patients get relief from their symptoms. Next slide. In terms of the paper and how we approached it, part of it was understanding the need, but a big part of it was talking to the CQC audience and community. So we interviewed a number of provider organizations, payers, and also managed behavioral health organizations to understand what was actually happening and to inform the research. Next slide. And what we heard was that there are a lot of barriers, not a big surprise. So the first barrier is really around provider participation. We don't have enough providers, they're maldistributed, and many of them don't participate in insurance networks. In addition, the directories out there might talk about who's in the network, but that doesn't actually reflect who has availability. And so, access is hard because networks are limited. We also heard barriers around coordination and communication. So one kind of very California specific thing that we heard is that, particularly in the delegated system, unlike the physical health system where the delegated entity creates a kind of a single workflow regardless of payer, in mental health, because it's not included in delegated arrangements, there are payer-specific workflows, which introduces a lot of complexity for clinicians and care coordination teams. We also heard that information exchange is really challenging, partly due to how people are interpreting privacy laws, not necessarily the intent of the laws, but how they're being interpreted. The cultural divide between the two professions, and the lack of shared systems between primary care providers and behavioral health providers, both of whom are, unfortunately, many of them are still on paper. And then last, but certainly not least, is reimbursement and risk. So part of this is about just limited reimbursement for behavioral health and low reimbursement. Part of it is about kind of fragmented accountability. So few entities have true risk for total cost of care. And we know that physical and mental health go together and compound each other in terms of costs and in terms of the implications for chronic disease. But that accountability is split. And behavioral health is almost always, except in the case of some Medicare Advantage, excluded from capitated contracts. So that makes it difficult to think about how to do integration if you don't have the revenue coming in to help you do that. So those are some of the barriers that we heard. Michelle, next slide. When we approach this, we take a very measurement-oriented approach. And when you think about behavioral health, that first manifests that measurement in terms of screening and asking people about how they're feeling. And so the really, really good news is that almost all of the provider organizations that we interviewed are recommending screening universally. And they're also all recommending the same tool. So from a measurement perspective, that's great news. The less good news is that very few of the organizations we interviewed had actually report on what percentage of patients were being screened. This is very different than what we would find in diabetes or hypertension, where everybody has that number at their fingertips. Physicians articulate concerns about screening because they don't know what will happen if a patient screened positive. And this data is a little bit old. We're actually in the process of updating it, but as a result, the baseline that we're seeing is that only about 1 in 3 patients are actually being screened for anxiety and 1 in 4 for depression. So that's a really, really low base. When you contrast that to the opportunity, so there are a couple places both in California and then outside California where we have multi-payer alignment for behavioral health. And one of those is in the safety net. So California FQHCs have a payment mechanism that's payer agnostic that enables them to do behavioral health integration. And at this point, 97% of the clinics in California are offering mental health services. Those services are growing and about 2/3 of patients are being screened. So this is one example where the safety net is just kicking out of the park relative to the commercial environment. And then if you look outside of California at the state of Minnesota, which several years ago embraced a multi-payer strategy to pay for integrated behavioral health care, they're now screening 75% of adults and 86% of adolescents. So we know that we can overcome these barriers. We know it's possible. It's just a matter of committing to do it. Next slide. So I'm not going to spend a lot of time on this. It's highly unscientific, but when we did these interviews, there were a few organizations that could actually report the rates of screening, and all of them had done practice change. All of them had done integration of behavioral health. So we think that if you want to get to measurement, you also have to do practice change. Next slide. And the practice change that we saw in situ in the places that had high rates of screening was overwhelmingly the collaborative care model, which is really the gold standard for behavioral health integration in primary care. There are 80 RCTs that back this up. It's cost effective. It's actually kind of cost saving, particularly among older adults or people with chronic illness. It's a team-based model. So it really starts with a primary care provider and gives them kind of 3 critical ingredients to help them be better equipped to deal with the needs in their practice. The first element is a behavioral health care manager who is taking that patient who screens positive and finding out what their needs are and supporting them with brief treatment. The second component is a registry. So that enables population health to really track over time, see who's improving and who's not, catch the people who are falling through the cracks. And the third element, which is also important, is a psychiatric consultant. So if a patient's not improving, there's an opportunity for that psychiatric consultant to support both the behavioral health care manager and the PCP, particularly on the prescribing side, to figure out how treatment needs to change to help improve symptoms. We could do a whole webinar just on this model, but very, very briefly, that's the model. And both Dr. Nelson and Julie live and breathe this model every day. So if there are questions about it, let's save that for their parts. They're much more expert than I am. Next slide. So looking at the research, our kind of strong hypothesis is that behavioral health integration will not spread unless we have multi-payer alignment. We can't have one way of paying from one payer and one way of paying for another. It's just not feasible for a busy primary care doc. And so we really see that there are kind of 2 possible actions and 2 ways that we'll need to address this in California, given the way that payment works. The first is outside of capitated arrangements, payers should just follow CMS's lead and turn on the collaborative care management codes. And these are monthly care management codes that are billed by the PCP and include the efforts of the whole team. And many, many payers have done this, and we're really grateful to those who have. However, in California, things are more complicated, right? We've got these capitated arrangements that often carve out behavioral health. And so there, I think we need to develop a standard approach that acknowledges the expanded scope of collaborative care and therefore may need to be contracted on the MBHO side or the physical health side. It doesn't matter as long as we're standardized. And it could be a monthly case rate that's very much like the COCM codes. It could be a monthly cap that's based on experience over time and includes care for people who are in the model and not in the model, adjusted per population. Or it could be another value-based arrangement. I think one of the strengths of the collaborative care model is that it's really, really strongly based on outcomes and on patient-reported outcomes and how those are changing over time. And so there's an opportunity here for more innovative financing that actually kind of pays for outcomes and rewards outcomes. And then the case of Medicaid, which I think is important and which is a focus of the paper, DHCS has not yet turned on the COCM codes. So the opportunities for managed care plans are really in that second bucket, even if they don't have capitated arrangements. So figuring out a value-based payment framework, but ideally one that really aligns with what other payers are doing so that it's kind of simple and easy for the primary care doc. So I'm going to turn it over to Crystal, and she's going to kind of get a sense of, for the folks who are on the webinar, where are we in this journey?
Great, thank you, Melora. And I see a question in the chat that, yes, we'll be sharing the PowerPoint slides. I think Michelle may be trying to upload the PDF right now, but we'll definitely get a recording of all of this, this webinar, as well as the slides in the email after the fact. So Michelle, if you could kick us to the next slide in the poll. So Melora shared about these kind of 6 levels of collaboration and integration, and given the wide variety of participants we have today, we just want to get a sense of where your organization may be, but acknowledge there's the 6 levels here, but also maybe you're very early in this journey, and so you have no integration. So if you'll take a moment to contemplate that and indicate it in the poll. And if this question doesn't apply to you, feel free to chat in some thoughts that you have in the chat box, or tee up some questions for Melora.
Sorry to ask of this. It looks like we're having some polling issues with capturing the results. So if you're comfortable sharing in the chat what your level is, you can just put 0, 1, 2, 3, 4, 5, or 6. Yeah, unfortunately, I haven't fixed this polling issue that we're having currently. Thanks.
Thank you, Michelle. So I'm seeing some early responses. Thank you. So some level 3s around there's basic collaboration on site, and some close collaboration on site. So in that kind of middle level there, around co-located, and there's some proximity to each other, but not yet, and really fully integrated practice. Yes, and as someone noted, within organizations, it can be very different across the entire organization when there's a high volume of PCPs, like 1,400. And so some are further along than others, given their practice situation. Cool. Well, why don't I take us a step forward? Thank you for those responses and contemplating that. And I think at this point we're gonna hear from 2 people who are on the ground doing this and have a few different approaches to this work. And first up, we're gonna have Dr. Tiffany Nelson from Desert Ridge Family Physicians and Innovation Care Partners share about her journey in Arizona, but in a situation of using technology as well as having the line payment and what it enabled her organization and her practice to do. Welcome, Tiffany. Dr. Nelson.
Hi, thank you. So if you don't mind going to the next slide. First and foremost, I just wanted to really thank you guys for having me from Arizona here. I actually did some work with PBGH quite a few years back. There was a CMMI demonstration project around the IOCP model, which we have actually used and integrated into our ACO. So very familiar with the organization, very happy to be here. And especially excited to talk about this topic. So I know I don't have very much time. I want to give you a brief overview of how we got there, what we're doing now, and then kind of some results just so you can see it's doable. I have a private practice. We have 10 physicians within our private practice. About in 2007, everything that was in Melora's paper we experienced. I hadn't read the paper, but I can attest that everything was there. So what we first started with was we did a survey of our existing patients and what kind of diagnoses they had, and we found that our number one diagnosis was depression and anxiety, more than hypertension, more than diabetes. And so it was something that we really felt like we needed to do a quality improvement program around. And so that's when we started screening our patients and making sure that we were also monitoring patients after we started them on some medication. And I can absolutely attest to PCPs are really seeing the bulk of patients with depression and anxiety, and that is, it affects a lot of what we do because it affects their other chronic conditions. As we were seeing that, during that time period, I would refer patients to counselors, and I never ever had collaboration with a counselor. And one day, lo and behold, I had a counselor who called me up and said, "Hey, I'm seeing your patient. This is what's going on. I'm a little concerned about her. What do you want to do?" So from there, I had the idea of, we really need to look at having somebody co-located coming in. And I was able to find an organization that basically was co-located. They did rent some space from us, and we worked out a model where it was just a sublease, but they would only see our patients. And the theory there was that a lot more of our patients would feel comfortable going to a counselor if it was in a familiar environment and somebody that was working well with us. And we would also be able to have better conversations about those patients. So we did that for about 2 or 3 years. The challenge there was that the payment mechanism was different. And so they were under a mental health payment mechanism. And so they didn't necessarily take all of the insurances that we did. And the reimbursement didn't work for them. And so they ended up having to no longer be co-located at our office because they could not figure out how to make that payment mechanism work. And so then we built this up. We had a lot of patients. We went from probably 10% of the people that we referred for counseling actually going and having at least one counseling visit to about 40% of our patients who we referred for counseling having a counseling visit. And so it left a void because definitely we had patients that were really liked the model, and we were seeing some really good results with our patients. And then came the collaborative care model with Concert Health, and it's been a really great model. The way that it works is that really they had designed under the model that Melora had shown, where the PCP would see the patient, we would refer them in. A lot of it is telecounseling. And then there is that psychiatric nurse practitioner who has some oversight only to help, figure out if a patient needs a different method of care, or to also give some ideas about medications should the physicians have that. What we had said is, we've got this on-site collaboration as well that our patients are really liking. So we'd like to have kind of a blended model where you're able to do this with telehealth, and then you're also able to do it by having in-person appointments available as well, because we need patients to, because some patients are more comfortable being face-to-face depending on what their situations are. So it's kind of the best of both worlds. The way that it works is if I'm seeing a patient, I have a referral management platform that I can send a referral over to the Concert Health folks, and they will reach out to the patient within 24 to 48 hours to then get them scheduled. They'll kind of talk through the payment mechanism and get the patient scheduled. And by doing a telehealth platform, we've got 5 different counselors who service our patient population. and it can be fluxed. So if there's a particular need, they're able to use a different counselor that may be more particular to what that patient needs. And it's also allowed for patients to have a little bit more flexibility in when they can be seen, which has been really a great great addition. So the one other thing that I'll add before we kind of go through our results is they do chart within our chart. So I know when my patients are seeing the counselor, and I can see that, which is helpful. But what's even more helpful is we do have a secure texting platform that we are able to chat with each other if we have if they're noticing something about a patient. So had a couple of examples where they've noticed patient is using more substances than we may know. So they want me to get the patient in sooner and let me know about it. Or patient is having some suicidal thoughts or things like that. And so that much more immediate feedback is it's almost crucial to make sure that we're able to get a hold of the patient and take the best care of the patient as we need to. So with that, I'll have you go to the next slide just so you could see. We started this in July of 2019 with kind of a slow rollout. We did a pilot and then we rolled it out to all of our providers. And as you can see, we've got a number of patients. These are all patients that are actually enrolled. And so it's a building population, but as you'll see that the patients also graduate from the program. So it's as you see the numbers going up, that means more people are being referred in, but we're also having a number of people that are graduating. So there's constantly new patients that are coming in. You can go ahead and go to the next slide. This just kind of gives you an idea of how many patients are referred versus how many patients actually come and are an active episode. So this is the time where I should mention the great thing about this program versus what we saw before with the co-management is almost every single insurance plan that we have pays for the COCM model. We have one plan that does not, which is Cigna. It's a commercial plan, and it really provides a challenge for us because I can tell my patients, I have a great model, I can have great people that can take care of you. Oh, but you have Cigna, so we got to do something different for you. And it really helps the providers to make sure to get the patients engaged by having everybody pay for that model. It's also a very easy model to understand for a lot of the patients because their payment is very similar to how they pay the PCP. So if they're paying a copay with the PCP, that's what happens if it's a deductible. But this lets you know that of the patients that we do, we're 61% are actually becoming engaged, which is a great improvement from the 10% that we had for usual care and the 40% that we had with co-location. You can go to the next slide. So a couple other things when we look at what is the quality of engagement that we're seeing. What we saw nationally that on average, most patients only have about 4 visits per patient, and they kind of engage for about 1 month and then they're done in usual care. With this, our average has been about 16 contacts per patient, and the average length of the engagement was 73 days, which is more than the double, which is also we're seeing when we go to the next slide, you'll see we're also seeing a lot better patient improvements. And the nice thing about the way that this model has been set up is if the patient feels like 30 minutes a week is going to work well for them, that's how they can do that. If they feel like they need an hour every 2 weeks, that works. So that it's a lot more flexible than some of the usual care that we had seen previously. You can go to the next slide. So this goes over just really kind of our month-to-month improvement rate, and just something to point out when you look in the literature a lot about how to, how do we measure whether or not a person is improved, especially when you're looking at depression. Typically, they will say 5%, or sorry, a 5-point reduction in the PHQ-9 means that that is something that you could say is an improvement. When Concert Health has been looking at how to improve it, their improvement is even greater than that. So they're looking at a 10-point reduction or a 50% reduction in PHQ-9 or GAD-7 scores. Which it's pretty significant. Patients are saying that they feel better by doing this. And so with this really engaged model where you've got the primary care physician encouraging it, also understanding what's happening with the counseling, and then really backing that up, and being able to flex and get patients in sooner if they need to, we've seen just some really phenomenal improvement rates. And then when we see improvement rates in depression scores and in anxiety scores, then we also see improvement rates in chronic conditions. So people are more apt to take care of their diabetes. They're more apt to take care of their CHF and their COPD when they are feeling better. When they do not have, when they're highly depressed, they are not motivated to take care of themselves. So we've definitely seen, even from the medical standpoint, that this has been a really great program. You can go to the next slide. So overall, I've kind of gone through a number of the different benefits that we have seen. One of the things that I didn't mention, and just to put it out there, is that by doing this, we've also been able to flag some patients that are at risk of suicide in primary care. And then we utilize the behavioral care manager to help do that safety plan, and then also identify that patient for the primary care physician, so we can get services in there much quicker than what we could have in that usual care. And I think on the last slide, it has just a little bit more about that. So we've been able to flag about 5 patients during this entire time. And then they use some evidence-based treatments, and then are also using the primary care physicians. Just a little bit about, I'll do just 1 minute about payments and what we've seen. The vast majority of our payers are paying for this, which has been, it's been just really a game changer. Obviously, we couldn't do this if we did not get reimbursed for this. It's a lot of extra service and things of that nature. But by having that payment mechanism there, it makes the physicians feel better about referring patients in. And we feel pretty comfortable that when we're sending a patient over, that it is going to be covered. A lot of the conversation at a primary care bedside with a patient is not knowing what kinds of things are going to be covered, whether it's medication, whether it's some type of treatment, whether it's a certain specialist. By having it integrated, and us really being aware of that we're getting that payment in, and that the patients are going to be covered, and giving them good expectations, it has really helped that conversation in order to make patients feel comfortable with even starting to try to engage in the service. With that, I am going to turn it over to Julie Fortune, who will give us her great information, and we'll be happy to answer any questions at the end.
Hello, I'm Julie Fortune. I am the Director of Behavioral Health and Primary Care Integration for our Providence St. Joseph system for our Southern California region. So today I'm really happy to share a little bit not necessarily the specifics of how we implemented our collaborative care model at St. Joseph. I had the opportunity to share that information, I think, at a previous presentation, some of the good, bad, and uglies of getting some of these programs up and running, but really wanted to focus some time today on maybe some opportunities or transitions we've made because of COVID-19 in this space. So next slide. So again, really looking at, we have a collaborative care, primary care integration program at Providence St. Joseph that's about a year running. So it's a program still in its infancy, still ironing out some workflows and bugs and billing, but we were really kind of hitting our stride at this 1 year mark. And like all of us in the room, with the in March, when the true stay-at-home ordinance and COVID-19 hit our regions, our areas, we really had to figure out how to pivot this work. And our executive team, our senior leadership team really got together to figure out a new way of serving our patients during this time, and how can we do that and stay as true as we can to our collaborative care model. And so we really focused in two areas, really about our therapists' ability to continue to provide quality, clinically efficient treatment modalities, but also their safety, and how are we going to protect them during this time. And then the second area was, how are we going to serve our patients and make this kind of behavioral health resource available to more folks? So I'm going to go into more details with those 2 points. So next slide. So our first concern was with our therapists. Now, with the collaborative care model, we had our behavioral health specialists, which in our system are LCSWs and LMFTs. We truly had them embedded in our primary care practices. So they were a part of the team. They had their offices. They were there Monday through Friday. They served the patients of those practice, the providers of their practice. They were part of daily huddles. They were really a part of that treatment team. And they had a mixed schedule. So they had some open slots and they had some standing appointments. So there could really be that true warm handoff from the physicians if patients needed that type of service, and is a huge part of our collaborative care model and work. And so with COVID-19, we had to assess the safety of our patients and our staff, and looked at moving our therapists out of the clinics, working in a remote space, and seeing patients in a telehealth platform. And so to move that, we really had to think on our feet and move towards really leaning into our telehealth department, making sure that our therapists had Zoom licenses, that they had workstations at home that were in compliance, that had IT's approval for usage, because we had been in the primary care offices and we had been using computers and stations that are a part of the clinic. So my therapist didn't have laptops that you can easily just take and go work somewhere else. So we had to make sure that we were in compliance with just again with legal and HIPAA regulations, and just making sure that they had a safe workspace. We also had to make sure that our work that we were doing in a telehealth platform via telephone were covered, or could be captured by our collaborative care CPT codes. So we worked really closely with our coding department and just made sure that our touch points were still appropriate for us to be capturing as part of our minutes that we that we are providing intervention for the patient. So we made sure to get their blessing and approval on the work that we were doing, and that this all fell into appropriate minutes for our collaborative care CPT codes. And really just still back one more, we had to have a lot of communication with our practices. We had to make sure that the physicians were still being engaged with our behavioral health therapists, that they knew kind of what our timeline was, what we were looking like in regards to being in the office, not being in the office. Our communication with the practice managers and the physicians of those practices was really important, because as what happens often is it's out of sight, out of mind. And one of the things we didn't want to see was that the physicians, because the therapist wasn't physically there at the huddle every morning, or they were not physically there in the office, that we would lose momentum on this program. And we were on an upswing. We did not want to see that falter. So we really upped our communication, just weekly emails, making sure the therapists were secure texting the physicians, keeping them engaged with their patients, and making sure that we had strong communication with them. And I think one of the important things during this time was really making sure that the therapists had the right clinical support during this time. They were so used to being embedded in the practice and being surrounded by their team, by their physicians, by their MAs, by the front office staff, and really being a part of something. And now we've removed them from that space. They're working in their homes, trying to see patients and just really lost touch with that team-based approach. So we started a weekly Friday lunch Zoom check-in with all of our teams, so all 12 therapists, myself, just all of us getting together so that we can have that camaraderie as clinicians. We can talk about the pros and cons of the week. We can talk about clinical successes engaging patients during this time. And it was a camera on meeting. So you had to show your face and not just be behind your name and black screen, and it really just allowed us to stay connected, stay motivated and excited about this work during this time. And then the next major focus for us, and that's the next slide, is really how are we serving our patients? And so when we started this program, we were focused on our ACO population. We were focused on the patients we were at full risk for. And so we knew what that looked like. We knew who we were part of a team-based approach. We knew what those payment mechanisms look like. We knew what billing looked like for that population, because this was a part of the service they were entitled to. But we noticed that when COVID-19 hit, we felt like this was the opportunity for us to open our doors to all payers and patients. We felt like this was going to be a need for all, and that we couldn't have our programs stay in just serving a silo population. And this has been a really challenging and an opportunity for learning, especially as we opened up to commercial payers. And I'll definitely share some of those challenges and successes. But to open the door to release that valve, we had to really partner with a few different departments. We had to make sure our contracting department was aware of what we were doing, and to ensure that our collaborative care CPT codes were a part of our current commercial medical plans, and really educating them that these were not behavioral health carve-out codes, that these were part of our the medical benefit and the medical plan, and really that the physicians are the billing providers. So a lot of education to contracting, and having their support and getting some clarity in regards to again, reimbursement rates, which insurances are covering this, which ones are still confused by this, because the codes are still relatively new. They were released in spring of 2018. And so everyone is still trying to get their feel for these codes. We also had to engage our billing cycle partners because they had to understand these codes as well. So a lot of education and getting them to not just default to what they've always done with, oh, that's a behavioral health code, let's kick it to the behavioral health carve out, which then gets denied and then gets kicked to the patient for a huge monster bill that shouldn't have gone to them to begin with. Or on the same side, our billing cycle team gets it correct and sends it to our health plan. And the health plan says, nope, that's a behavioral health code. We're kicking that back to you. That's a denial. So really trying to educate contracting, billing, our health plans, making sure they're aware that we had turned on these codes, that we're billing these codes to try to make these processes as seamless as possible, and knowing that that hasn't gone as smoothly as we would have liked, because I think even though we're all working together, there's still those bills that go out. And I think our, which does create some anxiety for patients because they get like $1,000 bill for our services or thousands of dollars. And you're like, no, don't worry about that. I'm so sorry. It's, we're correcting that on our end. That was a billing process, a cycle process issue. So it has very much been, a learning opportunity during all this. And then of course we have, and I can speak a little more on that, but our, just engaging our marketing department, having open communication with our PCPs about this kind of change for us, what does that mean? And just spending some face-to-face time or telehealth time with our Zoom time with our providers to let them know of these transitions. And so I just wanted to take a few minutes at the end just to talk about a few of the learnings in regards to payment for some of our payers. I know that it came up in the chat box earlier, and Dr. Nelson mentioned it. Most health plans are paying and reimbursing for this service as part of their medical benefits. So we are seeing that a lot of plans do recognize these codes and reimburse at a really nice rate, because they understand that this type of collaborative care work, it really embodies a really high level team. You have the provider's time, the psychiatric consultant's time, the therapist's time, and it really is a high, a really quality service. So it does get reimbursed at a great rate. However, I will caution, and maybe where we have seen troubles has been with our commercial PPO patients. That reimbursement, because our patients might have high deductibles or high share of costs, because our service, when we drop our CPT codes, it is a high cost for this service because of all the team members that are a part of this. If they have a high deductible or high share of cost, the bill to the patient is higher than they would have seen if they were just seeing maybe a traditional therapist in their network. So I think getting education to our patients about, or especially our PPO patients, about the true cost of this program and why the cost is so high because of the amazing team that they're getting, and really allowing them to have the option to participate in our program, or if they felt like going into their carve out in network is the right fit for them. So there's been just some challenges in our PPO market. A lot of our patients have chosen to go into their carve out plans because it was not as high of a cost, and they felt like that was something more doable for them for financial reasons. And I do have Beth Donovan on the line from Blue Shield, who has been an amazing partner with us during this time. And I wanted to give her just a minute or two to talk about, just to chime in on, as a health plan, how they have come alongside us to support us during this time.
Great. And Beth, while you mute yourself and get ready, can everyone type in questions they have? We'll probably have a time for 1 or 2 questions at the end. So go ahead and get those going. Thanks.
Sure, and thank you, Julie. I'm so overwhelmed with both presentations. This is really great information. And I just want to say, I think that exactly what you were saying is true. I just want to echo your comments in that I think although both organizations were really trying to do the right thing and make sure that the patients got the care that they needed, it was really working through the systems changing and making sure that things were set up so when claims hit, they were processed correctly. So I think that that is a big learning. I think if you're undertaking something like this, reaching out to your payers and setting that up in advance, and then staying in touch, right, Julie?
Yes, absolutely.
Ongoing conversation and, you know, those few bills that did get through to patients and denials that came through, that we were able to work through those and figure out where in our systems we needed to go. And I think the other big important thing is to realize, you know, I think on the patient side, it's really not one or the other or all or nothing. That, like you mentioned, some patients are better served in a carve out, you know, based on the complexity of their needs or particular situation, their deductible, all kinds of reasons. So realizing the importance of both programs and also setting up that relationship, I think was vital. Is now Julie's therapists all have, you know, the contact information at our carve out, and we're able to really do a warm handoff and work collaboratively to make sure the patient gets the best services. So thank you all for a great presentation.
Thank you, Beth.
Yeah, thanks. And so I want to jump back to a question that was before to both of you just quickly. Are you receiving any value-based payments that are tied to improve outcomes, so beyond the reimbursement and use of the collaborative care codes?
Not right now for us in Providence, St. Joseph. Dr. Nelson?
Yeah, no, we aren't either. Most of our value-based contract piece of it comes through our ACO, but still we're not seeing a lot of value-based that's directly related to behavioral health.
Any kind of tips on getting started or pitfalls to avoid? You know, both of you are kind of well into this journey. And to the other provider organizations on the phone, any suggestions?
I know that you have it on the screen there. The AIM Center and the AIM Center website is definitely very helpful to get information about just the studies set up. They have a lot of great information for getting started. I think the best thing that we did in getting this going with our organization was making sure we had a strong executive core leadership team who had input and buy-in on this type of work and what it would take to get this started and moving off the ground, and physician buy-in at all the sites of what this was going to take. I think really making sure to do a lot of groundwork and foundation work on the model and again, collaboration before you decide to jump into this work. Because if you're going to have a team that's resistant to this, it probably won't take flight the way you would want it to. But if you have a team who's wanting this, I think they will be flexible to your needs and getting this off the ground.
And I see we have a question from the audience. So this is a question for Dr. Nelson and for Julie. How do you get buy-in from doctors who are used to the old model of telling a patient to call for a self-referral to psychiatry? And how do you deal with the fact that some doctors feel they need a psychiatrist to see each patient before issuing a diagnosis and treatment plan?
It's a great question. I would say that I'm lucky enough to be in an organization that I actually don't see that a whole lot. At least in Arizona, the issue is that to get somebody into a psychiatrist, you're looking at a 2 to 3 month wait most often. And so trying to have a patient get into psychiatry it's really difficult. And so what I see a lot of primary care providers doing, I mean, they're really reserving those for the treatment resistant patients, or patients that may have more serious diagnoses, more severe bipolar or schizophrenia or that type of thing. I think that a lot of primary care providers are managing managing depression, or they don't know that they are not managing it. And so what I mean by that is I do have to say that there's a lot of doctors who will say, like, I can't just add one more thing in. And so when you talked about doing screening, they were really worried about, well, yeah, but they're here for their diabetes. Why are we doing screening? Because that's one more thing I'm going to have to say. My reaction to that is always, you're never going to get their diabetes under control if you don't know that they're depressed. And so it is important in order to take care of those other things. And I think that one of the things that we talked about was how important it is to understand. And a lot of times when you do screening, you find out that most people are good. And so even those patients that are on medications, a lot of times their PHQ-9s are really good. That just takes it off the table. I don't need to talk, I could just reinforce, yeah, things looks good. It looks like things are going well. So the way that we did it was, it's there whether or not you want to admit that it's there or not. It's affecting their care whether or not you want to admit that it's there or not. And wouldn't you like to have a place that you could send people to take care of a lot of the counseling? Because a lot of times if you don't have that place, then you're either stuck being the counselor or you're completely just missing that the patient needs that.
Great, thank you. I just heard the ding. That reminds me it's 12 o'clock. So thank you to all of our presenters. I mean, clearly a topic that we can talk at length about. So there's some actions noted here that Melora of coming out of this paper and things that you can do in your organization. And I just want to remind everyone to continue to join us for this dialogue and email us any suggestions you have, so that you can email us at either of those, or contact me directly if you're interested in work we're doing or want to collaborate. So again, thank you to Julie Fortune, Melora Simon, and Dr. Tiffany Nelson. We really appreciate all of your expertise. And thank you to you all. Have a wonderful day.
Thanks, everyone.
Thank you.